and welcome to Race Dental webinar series or Academy webinar series for managing patient expectations. As usual, you have a last 1 minute dash for the last people to jump on board. And whilst we wait for that, I just wanted to welcome people we've signed in so far. It looks to be one of our largest topics and one of our most attended topics today, with well over 100 people in attendance. Registrants from Australia, of course, New Zealand, United Kingdom, India, hello from India, United States, Singapore and Malaysia. So it's lovely to see such multiculturalism in today's globalised world. It's fantastic to see that a topic such as this can draw big numbers. And I will go on to introduce our speaker in a moment. Just while the last few people I can see are just starting to taper off now. But today's topic was one of our most requested topics from a number of our clinicians on what to tell your patients if something goes wrong, or what to tell your patients in the assumption that something may go wrong. And if you've done a lot of work in your time, if you've done a lot of Crown and Bridge particularly, then you've probably seen some failures. If you haven't, you probably haven't done so much. In the words of today's guest speaker, if you haven't had failures, you haven't done much work. But what do you say to your clients to maintain their trust, to gain their confidence long term, and should something go wrong, turn adversity into advantage and read the play as such to keep that patient's confidence? Today I'd like to introduce our guest speaker, Dr. Brett Taylor. Dr. Brett Taylor finished university, I hope he doesn't mind me saying, in 1985. He taught at Sydney University part-time as well. He was sat on the ADA Council. He was an LVI instructor, and we did a lot of work in the early days with the Las Vegas Institute. But at the moment, and I understand how well this gentleman or this doctor has performed in managing patient expectations. Recently, we've been working on a case, patient Leslie, I'm not sure he's going to mention it today, a 20-unit Crown and Bridge case with full bite management via TENSing, and a really difficult patient, difficult case, completely symptomatic patient. So with no further ado, the master of managing patients' expectations, Dr. Brett Taylor.
Thank you, Matt. I'd like to thank you for giving me this opportunity to work through my lunch for nothing. Very kind of you. All right, we'll jump straight into this, managing patient expectations. What I want to do is give you a bit of a journey on how I developed these concepts, the pivotal moments when it all came together, and what I do now in my practice every day. Managing expectations is a critical part of everything you do. I'm going to go through the 3 epiphanies that shape my thinking and how I practice every day. So these are things that happened to me that made me reassess what's going on and identify this as being something that needed to be addressed on a daily basis. We'll also go through the why, so why you need to manage patient expectations, the when, and this was one of my epiphanies. There is a time to do this. It's not when you think you do it. So managing expectations in the when, the perfect time to do it, is critical. You've got about 2 minutes, 2 minutes of a sweet spot when it'll work. There's the how. I'm going to give you some specific scripts I use, but I would suggest that it would be smart if you learnt the principles. You can apply this everywhere. And there's a don't. There's one big, very big don't that I don't want you to break. The don't will bring you down easily. Okay. So today is mostly about treatment expectations. So we're going to be focusing on treatment and post-operative pain breakages. You can manage expectations in every part of life, and you should be conscious of that on a daily basis. Poorly managed expectations lead to disappointment and dissatisfaction, and it doesn't have to happen. The way you set up a relationship, the way you set up an agreement will determine the satisfaction of that agreement. So let me give you a classic example, a tradesman. So you've got a plumber coming to the house. The plumber says, I should be there by 2. All right, so that's an implied contract. He's saying, I'll do my best to be there by 2, but all you heard was, you're going to be here at 2. So around about 3, he'll turn up with some lame excuse about the fact that he got held up somewhere else, with you becoming more unhappy by the moment. Contrast that to him, the tradesman telling you the truth of, I really have no idea how long my morning jobs are going to take. Any time I give you will be only a guess. Absolute best case scenario is 2 p.m., but I could be there as late as 4 p.m. Is that going to be okay? So what's happened there is I will agree to that. I'll go, yeah, sure. I know 4 is the last he's going to be there, and he might be there in a window. So by not offering a best case scenario, he has created a situation whereby I will not be unhappy with him. He's got 2 hours to get there. Now, I don't know if there are any lab owners listening at the moment, but labs are a classic for potentially mismanaging expectations. So, we as dentists, if we want something on a particular day, that's the day we want it. If the lab thinks it's going to struggle to get it there that day, the time to tell us that is at the beginning, not, the day before it arrives. And it's a simple managing expectations thing. I wouldn't have cared if the plumber got there at 4. I just need to know he's going to be there. He can't read the future. He doesn't know what his day is going to be like. So he has to try and be honest with me. And the way you couch that honesty is the way that you build successful relationships. I'll also give you some articles to access that I've written on useful practice applications of the principles. So emergency appointments, just like I mentioned with that example of the tradesman, there are ways to screw up your day and screw up your patient relationships by fitting patients into a schedule. That's in an article. That's not today's brief. Why do you need to manage patient expectations? Who wants unhappy patients? Okay, dentistry is hard enough to practice as it is. We don't really need to make life harder for ourselves by saying things that people don't need to hear that create problems for us later. Things will go wrong if you practice in the same location for long enough. I've been in this practice for 36 years. I see the work I did 36 years ago. A lot of it I'm proud of. Some of it breaks for inexplicable reasons. It's just the way the world is. But you need to set things up so that people are mindful of the fact that they can go wrong, and it's not your fault if they do go wrong. The urge to overpromise is great and invariably leads to disappointment. Do not overpromise. Never overpromise. You think you have to do it, but you don't have to do it. And sadly, a single disgruntled customer can ruin your business. Thanks for nothing, social media. So we have to be mindful about keeping people happy. The happier we keep them, the better off our lives are going to be. So this is Epiphany 1. I know we've got some overseas people tuned in, and an epiphany is a revelation. This is where I learnt a very, very valuable lesson. And I'm going to show you how to disappoint someone 44 years later. So this is Doris. Doris turned up to see me. She was 82 years old when this photo was taken in 2006. Doris had previously seen a very gifted dentist by the name of Graham Walters in Australia. He had done some good work for her. Graham retired and she got in the hands of someone who was a bit incompetent. All that crown and bridge work in the front was done 2 years ago. It was all falling apart and she needed a full clearance, her suggestion. So Doris and I are sitting there and we're looking at her mouth. And I said, well, yes, Doris, you can't afford to fix them and I think it's reasonable to take them out. I may not have done it now, but I did it back then. So Doris is looking at this screen, right? And she says, what about the gold tooth? Does it have to come out too? And I said, well, it's nothing wrong with it, Doris, but all the rest of them have broken down. It's okay. And she said, Graham did that for me after Brian was born. Brian was a friend of mine who I knew. I said, when was that, Doris? She said, 44 years ago. And she was disappointed that that tooth had to be removed. Okay. She wasn't disappointed in the idiot that had destroyed the rest of her dentition. She was disappointed that I had to extract the gold crown that Graham had told her would last forever. So because Graham inadvertently told her that would last forever, she got disappointed with him. Now, what should Graham have done? I was flabbergasted. I thought, the guy's done nothing wrong. He's a great dentist, but somehow he's disappointed her by something he said casually. I'm sure she said, how long this is going to last, Graham? And he would have said, it'll last you the rest of your life, Doris. And she took that to be true. And when it only lasted 44 years, she was disappointed. So what do? for managing patient expectations. I don't make promises, especially ones I can't keep. Graham should have said, the research shows an average crown lasts 8 to 10 years. I like to think my crowns are above average. I'd be disappointed if they only lasted 10 years. And you know what? If something only lasts 10 years, I am disappointed. If people press you on, oh, how long do you think it's really going to last? I always say I broke my last crystal ball and I can't seem to find another one. Don't get sucked into reassuring people. When push comes to shove, patients accept the truth. Patients know you can't predict the future and are not offended when you remind them of the fact. I don't know is an acceptable answer to a question. How long will it last? I don't know. None of us know how long any individual piece of work is going to last. We know how long we want it to last, but we don't know how long it's going to last. Now, I have a pro rata policy in crowns in my practice, so I do want them to last 10 years, and if they break under 10 years, I replace them. You know, if it's lasted 5 years, then I give them a 50% discount and doing it again, and the clock ticks over. So I guarantee my crowns for 10 years, but that's just in my head. No one ever gets told that. It's just what I think is fair. Epiphany number 2, ski boots and amalgam condensation. When I was a kid, I had bad teeth, and I vividly recall when I was getting amalgams put in, how relieved I was when I heard the amalgam squelching. Now, some of you younger people have probably never had that sensation, but I can tell you that as soon as I could feel that amalgam being squished into the tooth, it was like a wave of relief went over me. And that was because I knew the drilling was over. I call it the ski boot moment. Anyone who skis knows that the best part about skiing is when you take your boots off at the end of the day. So we have a ski boot moment in dentistry that we don't realise. And that ski boot moment is when the chair comes up. When the back of the chair comes up at the end of the appointment, that's the ski boot moment for patients. You don't have any idea how relieved they are that they've survived the procedure. That is the time that you get to deliver your information about the procedure. You have a minute or two of profound relief and euphoria to manage their expectations. And that's when I do it. So the chair comes up, they sit there, they're looking at me, they're so happy they can't describe it, and that's when I hit them. And you should never underestimate the importance of this time. You can say what you like, the patient is just grateful to be alive. So this is when I promise problems. So this is when I tell patients everything that can go wrong, and they don't care because of this euphoria of surviving a visit to the dentist. For some unknown reason, pain at home is tolerable, but pain in the dental chair isn't. People don't care about later, they care about now. They worry about the future in the future. They don't need to be consoled about the future in the present, so there's never a need to make promises about the future. I always underpromise the future because it doesn't matter. Underpromising the future will, however, make you look good. And that's the purpose of this exercise. So the how. I say a variation of this to every patient every time I give LA. We've done a lot of work today, and it's going to be sore when the numbness wears off. It should be sore getting better, not sore getting worse. If it's sore getting better, that's good. If it's sore getting worse, then I need to know about it. The decay was very deep and close to the nerve. There's always a chance the nerve can die. If that happens, it'll need a root canal therapy to save it. Right? So that's my standard pitch. I don't care how deep it is. If they've got LA, it's deep enough that it would have hurt them. And I'm going to promise them that they're going to get pain afterwards. It's going to be sore when the numbness wears off. Not it might be sore, it's going to be sore. It's a promise to them. After I give them the little speech about the nerve might die, they always say, how will I know if it needs a root canal? And my deadpan reply is, it'll hurt like hell. And then I'll follow up with, I wouldn't worry too much. It's not likely, but it is possible. Anytime a filling is close to the nerve, there's always a chance the nerve can die. So everyone knows there's a chance their nerve can die. If it happens, it's not my fault. They were warned at the beginning. No one ever asked me, why didn't you tell me that before I started? It just doesn't happen. For surgery, extractions and root canals, I have a slightly different script. So that script goes, this is going to be sore when the numbness wears off. I take some Nurofen in about an hour, hour and a half. You can take the maximum dose of Nurofen, the maximum dose of Panadol at the same time, but don't exceed the maximum dose of either. I suggest you take the maximum dose of the maximum Nurofen dose and take it up and top it up with Panadol in between doses if necessary. It's going to be sore, so don't be a martyr. So here I am verbally giving them a whole, drug regimen. I know that mixing Nurofen and Panadol at the same time is better than having them separate, but I like to have the Nurofen as the main thing and the Panadol in between. But what I'm doing here is I've given them a big speech on how much pain they're going to be in. So do you think they're going to be in pain? No patient should ever leave your operatory not prepared for the worst case scenario. And I can't be clearer than that. You need to plan so that in their head they know it's as bad as it can possibly be. The how is that you should follow up these patients the next day. So I suggest you should ring all patients who have had a local the following day, and you should ask them how much pain did they have. You don't ask them, did they have any pain? How much pain implies pain was expected. Did you have any pain implies no pain was expected. There's a massive difference in those two questions. Now, so when I ring the patient or the patient rings the patient, excuse me, I've got to blow my nose. So we ring the patient, right? Or normally my staff rings the patient and they know that they've got to ask how sore was it. So Matt, how sore was it? So 17 out of people will have no pain, okay? And you're expecting 17 out of 20 of your fillings won't hurt. So 17 out of people, I've promised them pain, 17 out of people have no pain. What's their conclusion? Brett's a genius. 2 out of 20 people will have some pain, but not as bad as I predicted. Conclusion, Brett's pretty good. 1 out of 20 people will have pain as bad as I predicted. What's the conclusion? Brett's a visionary. Now, contrast that with me telling the truth, okay? Which is it probably won't hurt. Just like, the tradesman's probably going to turn up at 2. Contrast that with me telling them the truth. So I've told them, this filling is probably not going to hurt, which is what I'm thinking, okay? So 17 out of 20 people will have no pain and think that's normal, okay? Because I said it probably won't hurt. All they hear is it won't hurt. So what's their reaction? Ho-hum. Brett's nothing special. 2 out of 20 people will have some pain when they're expecting none. So they will be annoyed, okay? I've said it probably won't hurt, and now they've got a bit of pain, they're annoyed. Their conclusion is Brett's slightly incompetent. 1 out of 20 people will have a lot of pain and will be very unhappy. And their conclusion is Brett's an idiot. So you can see here that by setting things up so that the patient is expecting problems, you're creating an environment where if there is a problem, it's not your fault because it's expected. If I have someone who has like an endo flare-up where they have significant pain, when I talk to these people, and if you can endo flare up, you can have a lot of pain. They'll say something like, "Yes, it was really sore, but you warned me. I was prepared." People thank you when there's a big problem. So as long as they're prepared, they're happy. And if it doesn't happen as predicted, they're still happy. Now, there is one caveat on the when. If you really want to cover your ass, you should provide written treatment information prior to treatment, including fees. The including fee thing stops any disputes over what was said, etc. So when I'm doing this, I'll always give them a patient information thing beforehand. So this is something that I've done. I've done these on all different procedures. It's all peer reviewed. So the way it works is they get these information sheets. I don't know how many people read them, but I've got this structure and a strategy that I've done where it goes by why is this being proposed, what are the alternatives, how is it done, and on the flip side, it's what should I expect after, what are the possible complications, how long will it last, and what do I need to do. So I've done these. These are available through SmileRight. I've got a financial interest in SmileRight. I need to tell you that up front. If you don't use our information sheets, you need to be doing something yourself in terms of providing them with information prior to the procedure. Epiphany number 3. And this is quite critical. This is the big don't. So I was at a driver's day for a Canteen, which in Australia is like a teenage cancer organisation. So what we did back in those days is we'd drive kids around a racetrack who had cancer, give them a good day out, and give them a bit of fun. So I went to one of these days, and that thing was sitting there, which is an Enzo Ferrari. It was made in 2002. 399 of them were made, and they were sold by invitation. This thing on this driving day, there was probably 1 or 2 of these in Australia. This thing on the driving day was sitting in the middle of the track with a vapor lock broken down. It cost $1 million 20 years ago, and it was new and it was broken down. And the guy who owned it was making every excuse under the sun for it. It's a complex sports car, and these things happen. And if it was my car that broke down, I want Enzo turning up himself to fix it on the other side of the grave. But this guy was making every excuse he could for this thing breaking down. And it taught me a very valuable lesson. And the lesson is, if they buy it, they own it. If you sell it, you own it. This guy had bought that car, and everything that went wrong with that car, he owned. If you sell treatment to patients, you are responsible for everything that goes wrong with that treatment. Patients should never be sold. They should buy. The distinction is subtle, but if you're the sort of person who's convincing someone that they need something done to prevent a problem, and presenting the case for treatment being undertaken from the point of view of you're trying to convince them, you're trying to push this idea on them, and they eventually acquiesce and buy off you, you've sold them, they haven't bought it, and you will own anything that goes wrong. If they choose to accept the treatment, if they choose to have the work done, and you've created the environment whereby they are buying off you, you are not selling to them, then they will own any problems that happen. I can't stress that enough. There are a couple of good courses on selling. I could run one, but I'm not in the mood. Mark Hassett, the Relaxed Dentist, he does some good sales courses. Most of what I learnt was from Dr. Michael Cernick. He's running courses now too. Michael's a genius in anti-sales, on not selling, on getting patients to want the treatment you're providing, but not you selling it to them. And I have no financial interest in that. More's the pity. Coming to the end of my presentation, if you want to learn everything that I know, you can buy my book. Available on Amazon. I have a financial interest in that. It's sent me broke. 30 years it took me to write down everything I knew, and there it is. Are there any questions? We will get to those in a second. Last thing I want to say is, if you do have any questions, you want to email me, that's my email address there. Happy to answer questions about what I've said. There are some articles that I've written that just go through what I've said there. Hopefully people snap photos of the screen to get the scripts, but there are some articles I've written in magazines over the years highlighting these things, or I can give them to Matt, and Matt can send them out on my behalf. Got through, Matt, with 5 minutes to go, feeling pretty proud of myself. Are there any questions?
Yeah, thanks, Brett. Look, firstly, congratulations, and your approach to managing patient expectations and under-promising and over-delivering. And I love the theory where if you get it right, you're great. If you get it mostly right, then you're a genius. And if and you get it wrong, then you've got a crystal ball. I think it's something that a lot of clinicians could use. We do have a bunch of questions come through.
Let me just say one thing. Can you hear me?
Yes.
Okay, so if I was you, right, and you just set me a difficult case, the first thing I would say is, Brett, how much trouble did you have setting that case? It was pretty tough putting it together. All right, so you should say to me, I'm expecting some trouble. That was a really tough case. And if I go, oh, you know what, Matt, it just sat in, you're a genius, then you look good. Or if I say, yeah, you're right, there are a couple of little things, but I overcame them. So by creating this, if you say to someone, it's going to be perfect and it's not perfect, you're setting yourself up for disaster. And, a lot of people, every part of your life, you need to be thinking about this stuff. If you overpromise, you really just do go backwards. Right, questions?
Yeah, so that full arch case I sent you, I was confident it was going to go in correctly, and I'm glad you had minimal contacts to play with on the day. But look, firstly, I'm rather disappointed. Firstly, that I've had no ski boot moments in the last 2 years, compliments of COVID. Yeah. But I'm definitely looking forward to when I can take on those ski boot moments again. We do have a couple of questions in from overseas. Hello, doctors. Thanks for the session. What would be our approach when patients come in with history of loss of filling done by one of your colleagues in a week of time, and he is blaming your colleague and giving history of irreversible pulpitis? Do you have a comment on that, Brett?
A lot of people get sucked into trying to do non-ideal treatment. So if someone, like it's what we call herodontics. So the first colleague has made a mistake by trying to do something that possibly wasn't possible. So if you're working outside what you know is going to work, then it's going to lead to tears. If you really are doing something that you don't think is going to work, you need to promise them it's not going to work. And I will promise people on a regular basis, this is not going to work. You are going to break this. I don't know when, but I know you're going to break it. So occasionally I get sucked into, well, at the moment, because of COVID, I've got a lot of people who normally get their dentistry done overseas, and they come in and see me, wanting me to put some crown back in that's a disaster that I wouldn't touch in a million years, and you've got to help them out. But I promise these people, this is not going to work. This is not ideal. It hasn't been done ideal. So in terms of, teeth people in the practice, we need to, if the person asking the question is the principal, then they need to know that the other dentist needs to do their work better. Or if they're doing compromised work, which we all have to do occasionally, then the patient needs to be completely clear that this is not the best you can do, and problems can occur as a result of it not being the best you can do. I've never had a tooth I pulled out jump back in the mouth. If you want certainty, you pull it out.
All right, we've got another one come in from offshore as well. Sometimes I've found patients expected no issue or pain after treatment due to their previous experience. When you tell them they will experience, they will not believe or not expect. How do you handle this situation?
All right, so pretend your arm's numb, okay? And you're looking the other way and there's a surgeon there. So the surgeon might have just scratched your arm, or he might have just cut your hand off. You don't know. The patient has no idea how deep that filling is if they're numb. If you're drilling on a tooth and it doesn't hurt, they have an expectation that you haven't gone very deep, but they can't see how deep the filling is. So, if you've done something, every patient thinks they've got a deep filling in my practice. And you know what? For most people, it is a deep filling. It's deeper than they want it to be. So just because it didn't, like if someone said to that, oh, my fillings haven't hurt in the past, I would say something like, just because it hasn't hurt in the past doesn't mean it isn't going to hurt this time, okay? Just because you didn't have a heart attack yesterday doesn't mean you can't have a heart attack tomorrow. Okay? The future is different to the past. I can't predict the future. I'm glad you didn't have any problems in the past, but this is a deep filling. Any deep filling has the chance to die. So you need to be prepared for the fact that it could be a problem. And it's not me, it's just the way it is.
And there's no doubt about it. That's a great approach. I do have one out of Queensland here. I believe you have a very successful practice in Penshurst. How long will it take me to own one of those Ferraris as well?
I wish that was my Ferrari. No, it wasn't, sadly. No, little BMW parked down the street.
Oh, tough life. Look, I don't have any more questions. It really sums up what you've done and how you've explained or simplified the way to manage your expectations. There's one more come through now. We do have another 2 minutes. Is it now a mandatory requirement to inform the patient of the outcome of no treatment?
All right. So in those sales things I've spoke about, I don't know if can you still see my screen here?
Yes.
So these things I do. Those information sheets I do, they do have, you know, what happens if you don't do something. And one of the alternatives is not doing something. So yes, obviously what I'm talking about with managing expectations here is what's occurring when you do something. Okay, you still need to do informed consent. People are still agreeing to be in your chair to do something, and they still need to know what you're doing and why you're doing it, which is why I like the written consent forms. But, you know, the written consent form isn't personalising what's actually happening on the day, which is what I'm getting to. So yes, you need to dot your I's, cross your T's in terms of, you know, having some sort of documentation. Like with SmileRight, we've got online consent. When they read the form, we can see that they've actually read the form, and it's documented in an online environment. But yes, not doing something is an issue. With you know, when I go through either Mark Hazard's system or Michael Cernik's system, one of the treatment alternatives I give people is nothing. So normally I give 3 alternatives. One is nothing, and I give advantages and disadvantages of nothing. Then I give a compromised treatment or a limited treatment, and then I give advantages and disadvantages, and then I'll do either a full mouth presentation or something that's more complex, and then I give disadvantages and advantages. There's reasons why you structure communication that way. But yes, you do have to mention nothing as an alternative. If you're trying to talk people into treatment, you are doing it wrong, you know, with respect. Patients should be electing to buy off you. If they buy off you, you have few problems. If you sell to them, that's where problems start. Yeah.
Look, there's no doubt, Brett, it's been much appreciated. We are running low on time. I hope that answers your question, Dr. Jeremy Rourke. We do have another few questions, but unfortunately we've run out of time today. Once again, Dr. Brett Taylor, we do appreciate your time, your skill. We hope we see you practicing in the industry. We can definitely learn from you for many years from now. I will get some of that information from you, Brett. We'll try and post it on the Race Dental website under our education section. If anyone wants more information on Dr. Brett Taylor's book, please contact Brett at edgedental.com.au or me, Matt at racedental.com.au. Please stay tuned on our next webinar, which will be snoring and addressing sleep apnea. But in the meantime, once again, thank you very much, Dr. Brett Taylor. Thank you all. Thank you, one. Thank you all. See you all again soon. Thank you.
Thank you.